Thank you very much, Reverend Adams. We now will hear from Mr. Lassiter, the Executive Director of the Henry Ford Hospital System.
That's all right. Good morning. The crowd's a little quiet this morning. Good morning, everyone. There we go. We want to make sure you're awake for the Surgeon Generals when they begin their comments in a few minutes. I'm Wright Lassiter. I'm the president of Henry Ford Health System, and I'm really happy to be with you this morning. I acknowledge Dr. Sullivan and all of our Surgeon Generals for being with us. And it's my pleasure on behalf of the Board of Trustees of the Henry Ford Health System, on behalf of the Henry Ford Medical Group, of which we have many members of the National Medical Association, and on behalf of our senior leadership of our system, that we welcome you all to Detroit. This is a really great event as we think about the 113th annual National Medical Association convening and scientific symposium. Our organization and our physicians have had a long and productive and rewarding relationship with the National Medical Association, and we're very pleased that you picked Detroit for your meeting. Today is even more special for me because I have the privilege to share with you that Henry Ford Health System and the W. Montague Cobb Research Institute are announcing a new research and training partnership to address health disparities. The Henry Ford and Cobb Joint Working Group will be established to promote research and development of new investigators to address health inequities. This working group will provide both training and mentoring to junior investigators who are seeking a career in research that is solution-driven. The initiation of this partnership, as I think most of us know, is desperately needed because African American and Latino communities in the United States experience significantly more health disparities than our majority populations. And clearly, given that those groups represent only 2% of NIH principal investigators, we need to address this issue. We also see much lower percentages here than with medical school faculty and with the general population. So clearly, addressing the issue of training junior investigators to provide key research and key solutions in this area is critically important. In 2011, after a report on racial disparities in grant funding, the NIH vowed to renew its efforts to create a more diverse workforce of researchers in their clinical and basic sciences. And it's important to note that the NIH Deputy Director for Extramural Research, Dr. Sally Ruckey, has stated the NIH can't do this alone. And so we believe very strongly that we are one of those partners to help push this initiative even forward. So what's needed to increase the proportion of federally funded principal investigators who are either African American or Hispanic descent? We need a couple things. First and foremost, we need a concentrated and concerted effort reflected in the commitment of time and a commitment of the right kind of resources, such as mentors and opportunities for connections and networking. We also need a pipeline. We need a pipeline to these talented young investigators, ready to step into the shoes of our senior investigators and healthcare leaders who've paved the way. And so it's our hope that this partnership will do a significant amount to further this effort. As we think about some of the Surgeon Generals in this room who have spent time toiling in these efforts, as I met Dr. Satcher last evening and learned that my father-in-law taught him early in his career, we think through all the things that individuals like Surgeon General Satcher has accomplished in his work. We think about the work of David Williams at Harvard or the work of Thomas Levice at Johns Hopkins. So it's really exciting for us to say to you that we are happy to launch this partnership. We're happy to continue the effort that Henry Ford Health System has had for a significant period of time, ensuring that health equities and disparities are reduced and addressed in this community. While I'd love to go on and talk more about things that we're doing at Henry Ford Health System, I look out and see some of my colleagues in front of me, and there's much that we could discuss, but since I was asked simply to give welcoming comments, I will cut off my commentary and cede the microphone. But I hope that you have a great symposium, and I look forward to meeting many of you throughout the NMA session the next few days. Have a good day.
Thank you very much, Mr. Lassiter. We now will hear from Mr. Paul King, Executive Director and Director of the Mott Children's and Women's Hospital at the University of Michigan School of Medicine.
Good morning. Thank you, Dr. Sullivan. I'm honored to be here today with so many former Surgeons General, for whose service we are forever grateful and indebted. Thank you guys for being here. As well as the distinguished members of the audience, physicians from most parts of the country, and other distinguished guests. Down the road about 45 minutes to the west, there's this little school called the University of Michigan. I know that many of you in the audience are rocking your maize and blue. I see some blue and maize ties out there and some shirts, so we're very pleased that welcome home for some of you. At the University of Michigan Health System, we are one of the health systems here in the state, and we're proud to say that we actually service thousands of Michiganders from throughout the state, from every county in the state, as well as for patients throughout the upper Midwest, actually right across the country and internationally as well. Eliminating inequities in healthcare requires ongoing diligence. Addressing unconscious bias among caregivers requires skill and persistence. Helping people with little money and perhaps waning hope get the world-class quality care they deserve requires passion and commitment. There's no shortage of those qualities represented by those of you in the room here today. The University of Michigan is proud to be a part of this tangible statement from the medical community, this visible statement that will no longer overlook inequities of care among people who look like me. We are proud to commit to graduating tomorrow's doctors capable, equipped, and eager to treat all of their patients with the care, respect, and professionalism that they all deserve. And we'll join forces with all of you in providing the research, training, and workforce that can help all of us as a country be better than we've ever been before when it comes to reducing disparities in healthcare. It's especially poignant that we're convening here today in Detroit, a city with so much good and so much heart, challenged like so many of our other urban centers with far too many people who face trauma, inadequate health care. One area that our Office of Health Equity and Inclusion at Michigan has made a top priority is examining and understanding the role that unconscious bias plays in the provision of health care of people of color and to people who are not mainstream in terms of where they live, who they live with, how they speak, how they look, or who they love. We're offering training and tools to help our doctors, nurses, therapists, and other members of our healthcare team understand more fully how we can both identify our unconscious bias and learn to minimize it for the good of our patients and simply to provide better quality care. So we're thrilled to participate in this session and to learn more about what we can all do by working together. As a hospital executive, I commit to you that we look forward to supporting the recommendations that come out of this weekend's sessions. Our goal is simple. We want people in need, whether they be black, brown, white, yellow, red, or tan, or speak Arabic, Farsi, Hindi, Zulu, Creole, or Spanish, to get the very best care that they deserve from our health systems. If that means examining more closely how our providers practice medicine, how they learn medicine, or how they interact with families, then we'll do that. In closing, let me say that I look forward to this morning's conversations, and thank you for allowing the University of Michigan to sponsor and participate in this dialogue. Thank you very much.
Thank you very much. We very much appreciate your support. I'm going to show only one slide to try and set the stage for what we'll be hearing today. As all of you know, in the United States, there's always been a disparity in this health status of the minority population as opposed to the majority population. This has many dimensions: poverty, lack of education, not enough in the way of health professionals, bias in the healthcare system, and other factors. This has resulted in disparities in health status. What this slide shows is throughout the course of the 20th century, there's always been a shorter life expectancy of the African American population as compared to the white population. That shortage was some 15 years difference at the beginning of the 20th century. It's narrowed to some 7 to 8 years now It is still there and remains as a challenge. This has many dimensions, and this conference is designed to look at those dimensions. We're very pleased that we have a number of individuals with us who will be giving their perspectives both as officials in our government as well as professionals in the private sector looking at issues of minority health and health disparities. Our first person we'll hear from this morning is our nation's current Surgeon General, Dr. Vivek Murthy. I'm very pleased that he was able to join us. He's been in office now, I believe, for just about a year, coming to Washington from the Harvard School of Public Health. And Dr. Murthy headed an organization looking at health disparities and access to health care. So let me present to you the nation's Surgeon General, Dr. Vivek Murthy.
Good morning, everyone. It is so nice to be here with you today. I want to first thank Dr. Sullivan for that very kind introduction, but more importantly, for his extraordinary leadership and for being a role model for so many of us, myself included. Please give him a round of applause. I also want to thank President Sanders for the invitation to join you this morning and for his stewardship of NMA. And most importantly, I want to thank all of you for welcoming me so warmly and for making me feel so at home since I arrived here yesterday evening. It's really an honor to stand with all of you today. As I mentioned to you yesterday, this is the first NMA conference that I have attended, and I'm so excited to be here. I'm also in particular proud to be with an organization that has its roots really in civil rights advocacy, providing really for the least among us, and an organization that has vocally supported some of the most important social and health policies for our country over the last century. I'm also proud to be in the room with some of our nation's most proud and greatest health professionals. As an organization and as individuals, many of you have worked for over a century, driven by a commitment to improving our nation's health, and I thank you for the invaluable contributions that you've made. Now, President Sanders invited me here today to talk about the issue of minority health and health disparities, and I will do that. But I feel that I can't begin without addressing the issue of racial injustice. Whether it's at the traffic stop of Sandra Bland in Texas, the shooting of Samuel Dubose in Cincinnati, or the killing of an unarmed group of worshipers in Charleston, the injustices suffered by African Americans have been on full display for the world to see these past many months. And while these incidents are not unique to 2015, the frequency and the violent nature of these acts have amplified the voices of those who say, never again. They have galvanized those who know words are not enough. And they have opened the eyes of many who thought that racial injustice was a thing of the past. It is absolutely clear, crystal clear, that as Americans we have a lot of work to do. Now, some critics tell me that as Surgeon General, it isn't my place to talk about racial injustice. And to them I say that until it is a thing of the past, it is every American's place to speak out against racial injustice. And it is also every American's place, including the Surgeon General's, to reaffirm now and again that Black lives matter. Today in America, as so many of us sadly know, who you are, where you come from, and whom you love plays too big a role in determining your health. Being poor, which affects 1 in 5 children, is too great a factor in determining who is healthy and who is not. In a nation as great as ours, a nation that my parents crossed oceans and borders to reach, that is simply unacceptable. These realities, they hurt all of us. They threaten our economy, our educational system, the productivity of our workers, and even our national security. They bend the arc of the moral universe away from justice. You may have heard me say this, but in case you didn't, let me say it again, that health equity is a civil rights issue. The principle of equity is at the heart of our values of a nation, even if it hasn't always been fully reflected in our practice. But it's also a value that I hold dear because of my own story and the journey that my family has taken. My father and mother grew up in a time and in a place where for many people in their native land, the respect that you received was dependent on the caste into which you were born. The inherent immorality in that idea that your birth determined your value struck them often and stung them in their daily experiences. They came to America hoping that they and their children, my sister and I, would not be judged by who they were born to or how they looked, but rather by what they could contribute to society, and as Dr. King would say, by the content of their character. And as much opportunity as we were afforded over the years, as we are blessed to have been brought up in this great nation, my parents could still not shield me from the subtle and overt racism that I experienced as one of the only Indian kids in our public schools. Those experiences left deep marks in me. They impacted how I saw myself and how I saw others in ways that were often draining and difficult. But they also sensitized me to the inequities that exist in our society, and they emboldened me to speak up against them as I grew up. Now, none of us can completely understand the life experiences of another individual or group. All of our experiences are unique in their own ways. But inequities harm all of us. They rob us of our dignity. They stand in contradiction to our values as a people, and they make us weaker as a community and as a country. All of us know that inequities exist in health. That's part of the reason that we have gathered here today. And this is true whether you look at rates of illness, at outcomes, or at access to care. We have heard, and we will hear more this weekend, about the severity and the extent of these inequities. But as I have traveled to communities, big and small, all across America as Surgeon General, I have found many reasons to be hopeful that we can overcome and address these inequities. First, I have met people who have struggled for years without health insurance and who have now been able to afford coverage thanks to the Affordable Care Act. I remember a particular woman in Virginia who struggled for years caring for 2 family members who were in nursing homes and for her child who had autism. And all the while, she couldn't afford insurance herself. The day I visited her community, she showed me the receipt that she had, showing that she had been able to enroll in coverage through the AC exchanges for less than $4 a month. And I will never forget the look of relief and happiness in her face. Expanding coverage to the uninsured has been a powerful weapon for reducing inequities. Among African Americans, the uninsured rate has declined by 9.2 percentage points, resulting in 2.3 million adults gaining coverage. All of you here in this room, and those of you who have been leaders and members of NMA who are not here today, all of you deserve a large measure of thanks for this because of the support that you have provided to securing this coverage expansion, and also because of the work that you have done to enroll people in life-saving coverage. So I want to thank you for the great work you've done to expand coverage in the United States. But the second reason I feel hopeful is because of the explosion of tools that are available to now help us understand and target health disparities, particularly in the realm of data and technology. The availability of population-level data and our growing ability to analyze and access this information is increasingly allowing us to identify where disparities exist and target our greatest efforts here. A new generation of technology is also making it easier to communicate and to bring services to previously hard-to-reach populations, as telepsychiatry, for example, is doing to connect growing numbers of people in underserved areas with care that has otherwise been hard for them to reach. And finally, and perhaps most importantly, I feel hopeful because of the people that I meet all across America. People who face long odds, but who find the courage and the creativity to design solutions for some of our greatest healthcare challenges. People like the men and women that I met in Birmingham, Alabama, who decided to run, walk, and swim together out in the open in their communities to set an example of healthy living for their neighbors. The same people who went door to door, knocking to recruit others to walk, run, and swim as well. But perhaps my most memorable encounter was on a plane that I took from Washington, D.C. to Birmingham, Alabama. And as I got off that plane, I realized that Miss Amelia Boynton had been sitting just a few rows in front of me. She was the brains, as many of you know, behind the 1965 March for Voting Rights from Selma to Montgomery. And Miss Boynton is the one who helped convince Dr. King and other civil rights leaders to make their stand in Selma. She was one person who had a great idea and figured out how to make it run, or in her case, march. I thanked Amelia Boynton when I got off that plane for training a whole generation of organizers who fought to redeem the promise of America. And I thanked her for inspiring me to do this work that is grounded in the fundamental issues of equality, freedom, and justice. And she smiled, she looked at me for a moment, and she finally replied to me, "Honey, I'm not done yet." Miss Amelia Boynton is over 100 years old, and she's not done yet. And the truth is that we're not done either, particularly when it comes to realizing the promise of health equity. As your Surgeon General, I pledge to you that health equity is not going to be just some section on our website that we will tweet about when convenient. In fact, during my tenure as Surgeon General, creating a culture of prevention and health equity will be the cornerstones of all the work that we do across all issue areas. We invest the majority of our health resources as a country in treating illness and only a small fraction in preventing it. I want us to be a nation that is as good at preventing disease as we are at curing it. I also believe that one's health shouldn't be determined by what zip code you were born in, what zip code you live in, your gender, your race, or your ethnicity. In a country as great as ours, every man, woman, and child should have a fair shot at good health. And this is not just a health issue, it's also a moral issue of great urgency. With these two guiding themes of prevention and health equity, my office is seeking to build initiatives in the following areas. First, on physical activity, where we will be releasing later this year a call to action on walking in walkable communities. Recognizing that building walking into one's day can improve physical health, mental health, and emotional well-being, we want to build a national practice around walking, but we also want to focus attention on the fact that not everyone lives in neighborhoods where they can walk. I remember caring for a patient once in the hospital who had been dealing with obesity and with diabetes for many years. And she had been told by many doctors, including me when I first met her, that one simple thing that she could do to help increase activity would be to take a walk after dinner. But what many of us didn't realize until later was that for her, taking a walk in her neighborhood after dinner meant taking the risk of being mugged or shot. And she simply wasn't going to do that. And this is a problem that too many people face in their neighborhoods, where safety issues and violence prevent them from going out and living the active lives that they can. The second issue that we plan to focus on is around prescription opiate abuse. Many of you know that the opiate epidemic has exploded all across America, in small towns and in big cities. In 2013, 11 million people reported the non-medical use of prescription opioids, and over 16,000 people died from prescription opiate-related overdoses. We have good reason to, in fact, suspect that that number is even higher. But the rapid rise in prescriptions that doctors and nurses and PAs and others are writing, have unfortunately been strongly associated with this sharp rise in morbidity and mortality over the last 10 to 15 years. And that's why we will be looking to build a movement in medicine, in dentistry, in nursing to reduce the prescription opiate problem by addressing prescription writing practices. We will also be seeking to do this by improving our training in how to treat pain, an area where many of us, as we went through training, did not receive a great amount of attention or focus in. Our third area of focus will be mental health and emotional well-being. And in this area, in the areas of mental health and emotional well-being, we will work with faith communities and health providers to change the negative attitudes that are still associated with mental illness, attitudes that prevent people still from coming forward and getting the help they need. Our fourth area is nutrition, where we are exploring ways to address the overconsumption of sugar in America, which is contributing to obesity and diabetes, conditions which disproportionately affect minority communities. Our fifth area is violence, where in particular we will be focusing on engaging men in ending this scourge of violence against women. And sixth, I would be remiss if I did not mention tobacco, where we will not only continue the strong legacy of our office and my predecessors, the former Surgeons General, but we will also focus on reducing traditional smoking, reducing smokeless tobacco use, and we'll also focus on increasingly addressing e-cigarettes, which are finding their way into the hands of children at an alarming rate. As Surgeon General, I want to modernize how we communicate about these issues, using traditional methods and new technology, recognizing that in 2015, many people don't watch the news and don't read the newspaper. They get their information from other sources. That means we have to deliver information using different messages, using different messengers, and using different platforms. But I also want us to go beyond disseminating information to working directly with communities to translate that information into action. That's why community partnerships with faith groups, with employers, with schools, and civic organizations are such an essential and important part of our work. Additionally, I want to say a quick word, but an important word, about the U.S. Public Health Service Commission Corps. It's a group that I am privileged to lead as Surgeon General. The Commission Corps is made up of 6,700 public health professionals who work each and every day to improve health in communities all across the nation in some 800 locations. They also deploy during times of emergency to address public health crises, as they have done during earthquakes, hurricanes, 9/11 and other terrorist attacks, and disease outbreaks. These brave men and women, some of whom are here today, are our nation's soldiers for health. They are driven by a passion to serve the underserved, and they will be essential as we seek to address the great healthcare challenges that we are facing. Now, as healthcare providers, you and I are keenly aware that health is not just about diagnosis and treatment, but we know that it's also about meeting people where they are. It's about building relationships that are based on trust. We know that public health doesn't exist in a vacuum. It's intrinsically linked to education, to employment, to the environment, and to poverty. The health choices that people often make are influenced most by forces in their community, and sometimes least by what we do in our hospitals and in our clinics. And that's why we need to help build collaborations across sectors with faith groups and with schools, with employers, as well as with civic organizations, and with people who may think that they have no role to play in health, but who can in fact make some of the biggest differences. Health is and has always been a shared responsibility. The only question has been, do we choose to recognize that? And our actions as a community must reflect this shared responsibility. Now, I need your help, and I need your partnership to address these challenges and to build a culture of prevention and health equity in America. I need your help to bring health messages to communities and to build these local cross-sector collaborations to address the underlying determinants of health. Because together, I want us to also help build a workforce that represents the patients that it serves and that possesses the cultural competence to deliver truly good care. This means increasing the number of minorities who are delivering care and who are guiding public health. And this is a goal that I am firmly committed to. In the end, we are living in a moment of unprecedented challenge and urgency. But we are also living in a moment of unprecedented change and opportunity. The challenges that we face are about much more than just health. They're about equity, and they're fundamentally about the kind of nation that we want to be. They're about whether we can make good on the promise of America as a nation that values all lives equally. It can be easy to feel discouraged by the magnitude of what lies ahead. But when I find myself doubting or wondering if we can do what needs to be done, I remember the extraordinary people that I have met during my travels as Surgeon General. I remember the great need they speak of and how they are looking to us, their healthcare leaders, for help. I remember the innovation that is already happening in communities all across the country, which often just need a little bit of support. And I remember a conversation I had years ago with a friend of mine, Lisa, who is a primary care doctor in Washington State. When we were talking once, Lisa revealed to me that she had the great privilege and honor to be part of the March on Washington years ago with Dr. King. And she recounted to me the uncertainty and fear that she held as she went into that march, that sat side by side with the hope and the optimism that she held, thinking that perhaps this could be a turning point in history for us as a people and for us as a country. And I'm so glad that it was, because for Lisa and for millions of other people, that moment, that March on Washington, was a moment, an inflection point in history. And Lisa told me that she tells her grandkids often about what it was like to be there with Dr. King on that day, to be a part of history, and to know that her voice and the voice of millions of others could make a difference. And I've thought about that story many times since then. I've thought about the moment that we are in right now, this important moment in history. And I've thought that if my fiancée, Alice, and I are so lucky as to have children someday, what would we want to be able to tell our children and our grandchildren about what we did at this extraordinary moment in history? Well, I want us to be able to tell them that despite all of the obstacles that we faced, despite all the people who said that things couldn't get better, that we never stopped believing that it was worth fighting for a nation in which every person has a fair shot at a healthy life. I want us to be able to tell our kids that at a time of uncertainty and great need, that we joined with the people and the institutions around us and restored faith in what we could do when we came together for a common cause. And I want to tell them that ours was a generation not defined by age, but by spirit, but a generation nonetheless of whom much was demanded, and one that stepped up and delivered, building a foundation of health for a nation. The NMA has long stood up for health and equality, and I traveled here today to tell you that you do not stand alone. I stand with you, and together we will make the promise of America real for every man, woman, and child. Thank you very much.
Thank you very much, Surgeon General Murthy. The Surgeon General will take one or two questions while the panel assembles of the former Surgeons General. Following the Surgeon General's questions, we'll then turn the program over to the moderator of with the former Surgeons General. So those who will have questions, if you would identify yourself, your name and your organization, and a brief question. Yes.
My name is Karen Taylor Crawford. I'm from Chicago, Illinois, Cook County Physicians. When will we stop using minorities and instead talk about people of color? We are no longer the minority in this country as people of color.
Thanks so much for that great question. And you're absolutely right that in the country, and particularly in many communities across this country, the people who were formerly referred to as minorities are in fact now in the majority. And so I think it is an important point for us to keep in mind. But what I often think about as well is that despite having come into the majority in many communities, we are still facing great health disparities. So this is about more than numbers, as we all know. It's about bringing in attention and focus and targeting our efforts at communities of color that have long been disadvantaged. And it's going to take some time to root out those disadvantages, but that's what I know all of us are committed to doing.
Good morning. I am Dr. Kamara Jones from Atlanta, Georgia, from the Satcher Health Leadership Institute at Morehouse School of Medicine. I'm also the president-elect of the American Public Health Association, and I was so heartened to hear you lift up both prevention and health equity and to call out racial injustice as one of your priority areas. In what way might the American Public Health Association and the National Medical Association, the AMA, and many other organizations join with you, because I plan to lead APHA in a national campaign against racism. So not even racial injustice, but racism, the system. Is there a way that we could join with you perhaps, and to what extent is your vision infused throughout the National Prevention, Health Promotion, and Public Health Council, your council that you convene? Is there a way that we can join with you and perhaps work with the National Prevention Council in getting this throughout all of our federal agencies?
Well, thank you so much for that question. And I want to say that we are very much looking forward to being at APHA later this year and looking forward to meeting everyone there. Your question is important because we don't just hope that groups like APHA and NMA will work closely with the Office of the Surgeon General, but we need you to, because we know that we cannot be successful in our mission without you. And here's why. Because our efforts to transform health in America, to build this culture of prevention and health equity, have to be about more than communicating about it and talking about it. We have to do that as well. But we need to reach people where they are. We need to be able to talk to communities with trusted voices. And those are the voices of doctors and nurses and others who care for patients. They're the voice of NMA members. They're the voice of public health leaders in APHA. And that's one of the reasons why we also, I brought with me today our new director of external engagement, Siobhan Arline Bradley, who came to us from the NAACP, who is very passionate about prevention and health equity, who is committed to building partnerships with all of you, and who can be the glue that connects you to the initiatives that we build and the campaigns that we run. And one last thing I'll say about this, just to make this very concrete. When I think about the role that organizations can play, I think about it, one, in terms of communication. One, for example, if we are building an initiative around mental health, and we want to focus particularly on eliminating the negative attitudes still associated with mental illness, then we want to have healthcare practitioners and faith leaders standing side by side in churches on Sundays, in mosques and in temples, talking to their congregation about the importance of mental health. When it comes to building a culture of walking and physical activity, we want doctors leading walks in communities to help get people active and show them that not only is it doable, but can it change how you feel right now, in addition to certainly reducing your risk for illness. So we envision very concrete ways that we can engage with and partner with you and have your individual members involved in our initiatives and campaigns. So I would encourage you to please talk to Siobhan. She's sitting over here. Siobhan, you want to just stand up? Give everyone a wave. There we go. Thank you. And I encourage you to talk to Siobhan, get in touch with us. We want to not only hear from you, but work with you. Thank you.
I know there's several who are standing. I think we should take one more question before we then go to the full panel, and Dr. Murthy will be part of that panel also. So let me ask Dr. DeBright if you would speak. And please make your questions brief, precise, as well as the answers.
Thank you, Dr. Sullivan. Thank you for coming. My question is on the pipeline as it relates to the upcoming review of the Fisher policy. What are your thoughts on that we've already had a favorable decision and now they want to come back and revisit it again? How might that impact our ability to develop a diverse, culturally sensitive workforce for the future?
I know our time is short, and there's a lot more I know we're going to say about workforce on this panel, but I will just say this, that as I touched on briefly, having a workforce that reflects the population that it serves is really essential. I was at an event recently with my fiancée Alice, who's Chinese American. And at that event was a Congresswoman, Grace Meng from New York, who is also Chinese American. And my fiancée Alice is a physician who's worked in advocacy for a long time. But for days afterward, she was talking to me about the fact that meeting Grace Meng made her finally realize that maybe she too one day could serve in elected office. And it was so striking to her because this is a woman who had been, Alice, who has been an advocate for years, who has worked in DC for a while, who theoretically understood that, but it was different when she saw somebody who was like that in front of her, who looked like her, who sounded like her, who was occupying a role she never thought possible. And that is why I think it is so important for us to move and to promote the participation and engagement of more people of color in the health professions. I think to do this, we need policies that are going to encourage that. We need to have aid policies and policies across the board that make it easier for minorities to engage in the health professions, for people of color to do that. But we need more than that. We also need them to desire and to want to go into the health professions. And the desire to go into the health professions won't come from policy. I think it has to come from all of us. It has to come from leaders who go out into communities, who help students understand that participating and being a member of the health professions is rewarding and possible, that it's something that people of color do and do successfully, and it's something that they can do too. The power of showing up of example, I think, is one that we need to utilize more, not just for participation in the workforce, but also for changing behavior when it comes to health. So, thank you so much, Dr. Bright.
Thank you, Dr. Murthy, for those poignant statements, and thanks for your vision as to what you plan to do in office. I appreciate that. I thank all of you who are in attendance, and we are going to move on. We're going to have a good program. Our former surgeons generals are here, and they will appear on your program, on the panel as they appear on your program from left to right. Dr. Benjamin, unfortunately, was not able to join us, and Dr. Carmona has a flight to catch, I'm told. And the next speaker will be Dr. Elders and Dr. Novello and Dr. Satcher. As moderator, and I hate to be moderator because I have to restrain myself and can't get into the fray, but as moderator, I'm going to ask the Surgeons General to try and limit their comments to 6 to 8 minutes to give an overview statement. That allows for more dialogue and Q&A, which you just saw, which many times is the best part of this program. I also want to thank the Surgeons Generals for what they've done in the past to make the health of this nation better with an appropriate and particular emphasis on those at greatest risk. Before I step down to my good friend, Dr. Sullivan, regarding life expectancy, I want to reaffirm the position he stated about their many dimensions, but as an obstetrician gynecologist, I would be remiss if I didn't emphasize for this audience that the most effective way to increase life expectancy is to reduce infant mortality, since life expectancy is set at the time of birth. And with that, we will have Dr. Carmona.
Good morning, ladies and gentlemen, and I would be remiss if I did not also praise Dr. Sullivan. You've heard so many great things about him, but for me, he is truly a health hero and a health warrior because he opened the door for all of us to be here today. So, Dr. Sullivan, thank you. I'm thrilled to be here with you today, and all of us, as you heard, were asked to keep our remarks short, so I will try and keep them brief. We're asked to comment a little bit about our tenure as Surgeon General and some of the challenges that we had. Well, one of the things that's apparent is that the Surgeon General really is a reflection of the times and how they serve. So as Surgeon General, when I came in, there's 2 wars, there's disparities, there's a whole host of challenges before us. And if you look at the history of each Surgeon General, you see that, in fact, each of us have reflected the times that we served in. The job of Surgeon General is to protect, promote, and advance the health, safety, and security of the United States. An extraordinarily simple value proposition on paper, but unusually difficult to carry out in a very hyper-partisan environment. When I first took office, one of the persons besides those that you see here who are my mentors, because there is no training program for Surgeon Generals, you just parachute in and you hit the ground running. But I remember sitting with Surgeon General Koop one day, and I was looking at all the data as far as the disease and economic burden and the challenges before us, and I was like, oh my gosh. And I looked at Koop and I said, you know, with all due deference, Surgeon General Koop, why did you leave all this stuff for me to do? And he said to me, son, you will understand soon. And it's true, because it's a very different environment that we get a chance to work in. Often as a Surgeon General, you're frustrated. And I used to joke that sometimes I felt like a cemetery caretaker. That is, that there's a lot of people below me, but nobody's listening. And then there are other days that I felt like a priest, because often I would go to convocations like this, like all the Surgeon Generals, and especially when I was in the White House and we'd be at what they called the mess, the White House mess, where the president has a little dining room and we'd eat, and the VIPs and dignitaries would come in and I'd eat, and often I'd sit at a table and I'd be at a meeting and they'd all come and sit down at the table, and the mess is run by a Navy chief, and he'd come and say, Admiral, what would you like for breakfast? And I said, well, go ahead and get their order first. And everybody'd say, no, have him order first. And you know why? Because after everybody ordered, and my breakfast was pretty boring. It was oatmeal, some orange juice, some milk, and some fruit. And everybody else would order their bacon and eggs and all this stuff. And then they look at me and say, you know, I don't normally eat like this, okay? So it was almost like you're getting a confession there as well. What's pervasive through all of us, all of our tenures, has been this issue of health inequity, of social injustice, of health disparities. And it really is a commentary on our society and how poorly we've done over time in dealing with these issues, because we know that the greatest indicator of health status in the world is your socioeconomic status. It is pretty clear in the work that David and some of our colleagues did in the social determinants of health. My bias as Surgeon General was informed by my childhood. I grew up in the hood, product of immigrant parents who spoke no English, and I grew up in Harlem. I was born in Harlem, and I grew up in Harlem. I know what it's like to wait on long lines at a public hospital to get health care. I know what it's like to be homeless and hungry. I know what it's like to struggle every day, not live paycheck to paycheck, but to live day by day. So that's the baggage I brought with me, because it was probably the best education I had to really be the Surgeon General. Because I've walked in those shoes. I understand those injustices. I understand the pain. I understand the indignities. I understand what it's like to be a person of color in a very white world where discrimination was rampant back in the 50s and the 60s. But yet, as I learned later in the Army, what doesn't kill you makes you stronger. And it did help me a great deal. So, just briefly, in my time, my portfolio was about prevention, preparedness, health disparities, health literacy, cultural competence, global health, and using health as a diplomatic tool, not only to eradicate these disparities, but with that comes economic opportunity. It gives people hope and aspiration so that there's a better world, that they can educate their children, that they can vaccinate their children, and people can be healthier. The health disparity issue hasn't changed, and the sad part is, through decades of service of Surgeon Generals, we all are fighting these same battles. It has been said that we are all created equal, but it's apparent to most of us that some of us are more equal than others. And that's been a challenge for all of us through the years. You know, I remember a story. As many of you know, I started out as a surgeon, and I went into public health as a second career, went back to graduate school. And of course, as a surgeon, I call myself a recovering surgeon, because, you know, if you ask a surgeon to name the best 3 surgeons in the world, they always have trouble naming the other 2. And I remember this, you know, some of these little vignettes that talk about the politics. When President Reagan was in office, and there was an attempt on his life, and he was taken into the GW hospital, and the trauma chief there was a guy named Giordano, trauma surgeon. And the president was very jovial, although he was hypotensive and he was in shock and having all kinds of problems. The Secret Service was worried. And the trauma surgeon went over to him and said, Mr. President, you're bleeding into your chest. We have to get you into the operating room. This is a true story. And the president was shaking everybody's hand and being a politician, even though he was in shock. And the president grabbed Dr. Giordano's hand and said, okay, doctor, take me to the operating room, but I hope you're all Republicans. And Dr. Giordano said to him, Mr. President, today we are all Republicans. That was the right answer, because what it tells you is health does not have a party. Health disparities does not have a party. And the problem is we have a problem with our politics in this country. So maybe to point out some of the obvious, Dr. Murthy, I think we would all just get up behind him and say ditto. We are on that bandwagon with him, okay? We understand. And one of the things we all agree on, once a Surgeon General, always a Surgeon General. So we're all on the same team. We're all preaching the same gospel. The challenge, of course, is this. You heard my portfolio, but within that portfolio and within all of their portfolios was this variable that we call politics. And why is that important? Because politics has a morbidity and mortality of its own. Now I'm going to tell you why it's so important. It's a nuisance. We're all embarrassed about the things we hear and see. Don't forget that when good policy is not promulgated, when bad policy comes forward, there is a morbidity and mortality with that. In my tenure, stem cells, abortion, Plan B, disparities, they all became political, volatile subjects. Yet for each of us, looking through a scientific lens, there was a clear path forward. The Affordable Care Act, which we argue about today, okay, is about social justice. It's about health justice. It's about correcting inequalities. And the Democrats got beat up for that. But do you know where that came from? If President Romney had won the election, we'd have Romney Care today. And you know, it would look just like Affordable Care Act, because he did the same thing in Massachusetts. That's the challenge with politics. It is so disingenuous. The Democrats were beat up because they were forcing people to enroll in health care. That was a Republican initiative decades before. This is about people. It's not about politics. And as Surgeon Generals, we recognize we are not the doctor of the Republicans or the Democrats. We have a much more important job. We are the doctor of the people. We do what's right based on the best science. Now, we can't correct these problems today until we address many of the issues that Surgeon General Murthy mentioned. We cannot achieve health equality until we have social equality and social justice and correct those injustices. We are inextricably tied to our past, and I'll close with just one remark from German philosopher George Hegel, who back in the 18th century noted, what we learn from history is that we learn nothing from history. And today we have an opportunity. We're at a critical juncture where we must change the way we do business in health. The disease and economic burden that's upon us continues to mount. It's disproportionately represented in people of color. And even if you don't have a heart and you don't have compassion, make a good business decision. Fix the damn problem. Thanks very much.
Thank you. Good morning. We certainly want to thank the NMA and especially Dr. Sullivan and the Wayne Medical Center and the University of Michigan for having us here. We like to convene every once in a while because we all like to talk. And so we're very pleased to be here. And we're going to get through. And I have some slides, but I'm not sure I'm going to show my slides. We can put them up, but I think that I'll just say my 5 minutes worth and things we all know. We know the population's changing. You know, by 2050, we expect 50% of the nation to be a minority population. So we've got to change what's going on. And just because our population has changed, the percent of our population that's represented by people like in this room, healthcare providers, is only 4%. We're all ashamed of that, and we've got to fix it. And we're going to, and that's a part of the health inequities that we deal with. We know that the nature of disease is changing. Our disparities are persistent. They haven't changed. They remain the same. One of the other things we know is we're the richest country in the world. We've got the best doctors, hospitals, nurses, research in the world. But we don't rank #1 as the healthiest population. We've got a very expensive sick care system. I think every Surgeon General, we've all been out there working and talking and trying to change it, and we're pleased to have the Affordable Care Act, at least as a start. As you heard, every president has been trying to change and get a health care system for the past 100 years. And you may not like the Affordable Care or Obamacare or whatever you want to call it, but let's not throw it out. Let's fix it. And I think that that's the best hope we've got, is to try and fix it. So we've got to change our expensive sick care system into a health care system. We all know the factors that are affecting health, and I don't have to go through them. We talk about poverty, education. You know, you all know that when I talked about sex all the time, I always said that the best contraceptive in the world was a good education. And if we want to change and reduce poverty, and we know the most common cause of poverty is children born children. So those are the things that we've got to fix. And we know that we need to make sure that we have access to health care. Dr. Satcher has always talked to us about provider access. You know, we've got to have doctors like yourself, but there are not enough. We're 13% of the population is African Americans, 4% of the doctors. So we've got to have more doctors that look like us. We were talking about poverty. We talk about where poor people are. We know where they are. We know them. We see them. And we don't have to tell you about them. We talk about cultural access, transportation access. And we look at the problems related to disparities. We got problems related to the system. Our system has a problem. We've got to fix it. We've got problems related to the providers. Our providers carry the same providers on their backs that our communities provide. They're from our communities. We've got problems related to our patients. You know, we don't educate our patients. They can't do what we tell them because they don't know how. And we're going to have patient-centered health care. We're going to have to make sure that we educate patients so they can help us be good patients. They are going to be the greatest help that we're going to have in the 21st century to make a real difference in health care and what goes on. We know that our health care system is at a crossroads. We're presently spending 17.9%, it's 18% depending on what day you look, and it's projected to go up to 20% of our budget. And this is something that we've got to deal with. Before Affordable Care, 21.7% had no health insurance. Now it's down to 11%, but that's far too many. Every person in this country should have health care as a human right. We know that we've got an aging population. I'm proud about that because I'm a part of it. We're living longer, and the fastest growing segment is going to be our over 85 population. We're getting fatter. When I lived out on the farm, I was sleek and thin. Dr. Foster was reminding me of that this morning. But you know, now that I sit home and pretend I'm thinking, but we've got to commend the Surgeon General for talking about exercise. My husband out swims every single day of the year, and he's nice and sleek, and his wife keeps getting fatter. But and Dr. Novello calls me every time I'm supposed to wear this uniform about a month in advance and remind me that I've got to put this uniform on. So I'm going to heed my Surgeon General's advice and go on a diet. So maybe this has been good, but as you can see, we're getting fatter. We're getting more obesity, which is because we're getting fatter, and that's something we've got to do something about. But the thing I talked about as Surgeon General the most is because our sexual burden of disease, 18% of the total global budget is spent on sexual health, on sexual diseases. 32% of the burden of disease is born of our healthcare budget is spent on women of reproductive age. And yet, we don't feel we need to talk about it. Medical schools, we had a summit on medical education, sexual health and medical education. And do you know how many the average number of hours that medical schools spend on sexual health education? It's 5. We've added 1. 5 hours. And it consumes 32% of the budget, and we can't talk about it. We know that we're not a sexually healthy nation. You know, we talk about our values. Look at the problems we're having with child sexual abuse, date rape, intimate partner violence, and I'm very pleased that the Surgeon General is going to address that. College sexual assault, it's on the TV every day. LGBT, transgender abuse. Then you say, we wonder, well, did this just start happening? No, it didn't just start happening. The news media is doing more to make us recognize it and deal with it. So I think we really, if we don't ever talk about it, we aren't going to ever deal with it. And I'm very pleased that because, I have no regrets as Surgeon General about talking about sexual health and preventing teenage pregnancy. I felt very strongly about that. And I want to thank you for making sure that we have markedly reduced teenage pregnancy. I understand in some of your cities, black teenage pregnancy has been reduced 60%. And that's because of the hard work that many of you have been doing, and I'm very pleased. If we look at ethnicity, you can see that black teenage pregnancy, the black line is for America, but for all of America, teenage pregnancy has been reduced by more than 47%. So that's saying we are committed to reducing poverty, ignorance, and enslavement. And I want to thank you for doing that. We've done a lot. We've got a lot of challenges ahead. We've come a long way. We've got a long way to go. And so I think we as Surgeon Generals want to do everything we can to help you achieve your goal. And our main focus is going to be on prevention. I think that we've got to prevent these problems and not keep trying to fix them. So, and I want to thank you for all you've done and all you continue to do.
I don't like to follow Joycelyn. The only time she has followed me is when she became Surgeon General after me. But I want to thank all of you for being here so early. I want to thank Dr. Sullivan for making sure that I became the Surgeon General, and I kill you sometimes for that. I want to thank Dr. Foster for being the moderator and really taking good care of me. And I want to thank Roy, because I met him a long time ago when he was young and he didn't have white hair. But at this stage of the game, we were asked, and I like to thank Dr. Murthy, that sometimes I think he could be my son, but he's behaving pretty good. So I want to talk about disparities because this was something that was there during the times that I was Surgeon General. And every time I look at the way that we are, I remember that it was almost 25 years ago that I was Surgeon General. I was a very young person. And I have the feeling, like Joycelyn says, it's not that we're getting fat, it's that this stupid laundry is getting this uniform smaller. So in this United States of America, we are 318 million people. We are 63% white, 16% Hispanics, 13% African Americans, 5% Asians, 2.4% multiracial, and 0.4% Native Americans. 38% of the United States is minority, and by 2060, it will be 56%. For the lady that asked about being minorities or not, we are the emerging majority, and in the year 2043, the white majority will be gone. Until then, we have to wait. Today, 46 million Americans are poor. It's the largest number in the last 54 years. 106 million live close to poverty. 20 million live in deep poverty. 17 million are in food insecurity life. And when you look into that, 27% are blacks, 23% Hispanics, 9% are white, and 0.5% are Asian. So I think we are in a threshold in America. It seems to me that which way do we go? Do we continue the old initiatives, or do we move in a new direction? Hippocrates said, extreme illnesses require extreme remedies, and I think the time has come for us to have an extreme remedy to something that, as the time I was Surgeon General, we have been talking about it and doing absolutely not enough about it. Martin Luther King said, the ultimate measure of a man is not where he stands at moments of comfort and convenience, is where he stands at times of challenge and controversy. It seems to me that we are in a time of challenge and controversy because the people of racial and ethnic minorities have not really gone very far in the last 200 years. I think it's time to candidly admit that in the year 2015, we still have a long way to go. So if we have learned anything about eliminating disparities, it's not an easy task. And the most important thing is you have to break the root causes that is getting us there. The poverty, the lack of education, the lack of economic opportunity, the lack of health insurance, no quality health care, discrimination, and in the African community, distrust of the system. In our quest to address this, people forget that the barriers is not only poverty. For some people, there's no time to take off from work to go to see a doctor. There's no transportation money. There's no buses. There's no navigation in a healthcare system that is complicated. It's not only follow the yellow line. And on top of that, if you happen to have a face that does not look like the one behind the line, they speak loud, like if being a minority means you're deaf. Then you have to ask the people who live in the communities, and they will tell you. We, the people, minority in this country, live in a place where healthcare people do not know my language. They absolutely do not know my culture. They do not give me the same education and respect, and worse, when they have the treatment that is high technology, I do not get offered it as the same as the white people with the same insurance. So the most important thing we have to do, we have to use the power of information. If you don't tell people what they need to know, how in the world they're going to know it, especially when minorities get their news 67% of the time from the radio or from the television. And more than anything, if you tell people what they need, 91 million people of us, will be able to trust you and will never turn away anywhere else to get their knowledge. So how are we going to accomplish this business? The most important thing that we have to do is socioeconomic causes and health disparities have to be addressed. We know that health, socioeconomic, and education go hand in hand. If you do better for education, the health would absolutely get much better. But more than anything, according to the Centers for Disease Control, 4 times as high persons living below the poverty line will really have complications in their health status. So when you look into this, today in the United States, if you have a high-income group, you are going to live 6.5 years more than the ones who do not have money. And if you're a college graduate, you absolutely will live at least 5 years more than the average person. So education is going to be very important. So health, education, and income go hand in hand. If you have no high school, you will earn $24,000. If you have only high school, you will earn $35,000. If you are a bachelor's, $64,000, master's, $81,000, and a professional degree, $115,000. So I have to tell you that education has a lot to do with what are you going to do with your life. So educational attainment is something that we have to look, but when you look at the numbers, my God, where are we going? If you do not know where you're going, you are already there. So when you look into high school, 75% of Latinos and 70% of African Americans get their high school diploma, but 15 years less than the average United States, which is 81% graduation in high school. And when you go to college, the whites is 40%, the Asians is 58%, the blacks is 20%, and the Hispanics 15%. Graduation matters. The unemployment of the persons with no college is 17%, and even when you have college, the unemployment is 7%. So when you look into this, I figure, what is going to happen for us to get beyond the high school? And let me talk to you about the people of us that is going to medical school. The Council of Medical Education said, although minority physicians are more likely to practice in the areas of the neighborhoods where they feel more comfortable, the recent figures of minority applicants and enrollments in medical schools have a lot to desire. According to the American Association of Medical Schools, 6% of African Americans matriculate, 4% only are practicing, and of the African American doctors today in the country, only 3% are male. And 2.3 really are men, and 3.8 are female. So when you look into that, why in the world are we just making sure that you tell me I need to be a doctor in medicine, and then you make me apply to medical school, and then you don't choose me? Something has to be done regarding that. And more than anything, it has been shown that African Americans tend to prefer the physicians with their own race, and more than anything, we give them 2 more minutes of time. We have cultural sensitivity, and we have interest and responsiveness, and we might even know their name. Remember, consistency in relationship with your primary provider helps minority patients with the mistrust of the system, especially when you try to bridge the cultural and the linguistic gap. So more than anything, I say that you have to have more sensitivity in medical school. To begin, I think we have to address the education of physicians. Cultural sensitivity has to be the center of medical school education today. I have to believe that that's the case. Let's face it, we come to medical school with 25 years, and in those 25 years of experiences, there is bias, whether it's gender or whether it's racial. And if medical school's training do not address this, then we're always going to be the problem rather than the solution. And believe me, I say sensitivity, not competent, because we get in there by being competent. So let's improve the communication skills of physicians, how to interview them, how to care for them, and by all, do not judge them for what they say, and share their cultural values. The reality is that there are 14 million people in the United States that do not know a word of English, and they also need to be addressed. Patients always are telling me, doctors see me too quickly, they speak words that I do not understand, and I'm so embarrassed to ask them for them to repeat them with the fear that they might think that I'm stupid or dumb. And more than anything, give them the information that they can understand. The focus in medicine today is fix it and heal the sick. The time has come for us to do more than the fix approach. The word doctor comes from the Latin docere, which means teach and instruct. I think the time has come to get the teacher back into the doctor. Remember, one thing that is the one that is most devastating to me, and perhaps it might help if we put all our efforts together, and might be not the easiest to fix, is what I call the barrier of institutional racism. the maintenance of disparity that is caused by the actions or the practices of institutions. I have been told that private patients can see their doctors in the private offices any day, any time. But the poor patient can only see their doctors only in the clinic on appointed times. And so there's a two-tier system in which the doctor of a private patient sends a note or calls immediately the referring physician once he has diagnosed the referral, where the clinic patient sees a resident in training, and most times there is no follow-up. And even more commonly, the next time it might be a different resident, a different clinic, and a different day. Could it be feasible to say that the reimbursement system unintentionally might be relegating the poor people to be served by institutions, training clinics, and teaching hospitals rather than granting them the same access to same facilities and systems of care utilized by the paying majority? I know that this is not for us to ponder, but I do believe that it's also a hindrance. I wonder what message we're giving the new medical students. Training, what good will it do to train them in cultural sensitivity and competence when they will be sent to work in institutions where from the first day they will find themselves working in systems that teach them that the poor is where you learn medicine and the rich is where you learn billings. I have the feeling that we have to be committed to provide high-quality medical care with our own clinics. As clinicians, you have to do more to ensure that the private practices have to also help the ones out there. Better services for people in the absence of better hours, it will not suffice. Our patients have to be partners, not supplicants of care. So where do we go from here, you may ask me? And I believe that eliminating disparities will take time, one at a time, one disease, one health center, one neighborhood at a time. But whatever efforts we're going to use would be no less profound than the efforts required during the first civil rights movement, efforts that were responsible for transforming the society at large. And one of the things that I did when I was Surgeon General, I did the Hispanic agenda. The time has come to have the African America health agenda totally separate from everything else. The blacks in the north are not equal in the needs of the black of the south, nor the east, nor the west. The time has come for us to divide the country in four, find out what are the needs, and then take it forward. I suggest that the Surgeon General and the Office of Minority Health draft the health agenda of the African American of today. And believe me, we will move much further because it will be in the eyes of those who can make a decision, and it's not just words in the sky. Make it education, make it health, make it data. If you do not know who we are, how can we plan the system of care for the people? Do not get complacent just in the healthcare reform. You have to move farther than that. So how are we going to begin? You're going to fund projects in the community, involved with the people in the community. You're going to make sure that you're going to define the programs very, very comprehensively. Then you're going to find institutions that have a sense of collaboration, and then you're going to provide the money for the funding. But more than anything, you're going to make sure that this is a long-term problem, so you're going to offer long-term solutions with long-term funding. There's nothing more distressing than to be able to have your grant and then make it stop in the second year when your ideas were just going forward. So get involved in frequent evaluation of the process and make sure that you get the outcomes that you deserve. Remember, Shirley Chisholm used to say, most Americans have never seen the ignorance, the degradation, the hunger, the sickness, and the futility in which many other Americans live. They will not become involved in economic or political change until something brings the seriousness of the situation to them. It seems to me that we Surgeon Generals have brought the situation to you. But I want to leave you with the words of Yehuda Bauer, the great Holocaust historian who said it best. And he said there should be 3 extra commandments to the ones we cherish and we honor. And the first one is, thou shalt not be a victim. The second one is, thou shalt not be a perpetrator. And the third one is, thou shalt not be a bystander. Don't let anyone say that enemy has ever been a bystander. Thank you very much.
Dr. Sullivan, Dr. Foster, Surgeon General Murthy, and to my colleagues, the former Surgeons General. I feel a little bit like the guy in the church where I grew up back home. He would get up at the end of service on Sunday and say, well, just about everything that needs to be said has been said. Then he would clear his throat and say, but not everybody has said it. Well, I know you want to get to the question and answer session, so I'm going to make a real effort to be brief. I have really appreciated the comments of the former Surgeons General and the outstanding presentation of Surgeon General Murthy. Let's give him another hand. So I just want to briefly review the areas that I tried to deal with as Surgeon General. And I must say they were greatly influenced by the experience I had had, especially as director of the CDC. And as you remember that time when we had the president to apologize for Tuskegee and reviewing that whole history, the efforts to eradicate polio, including immunizing 100 million children in India in 1 week and learning a lot about teamwork, but also working with an acting Surgeon General in bringing forth a report on physical activity and really realizing how few Americans were physically active on a regular basis. In fact, we found that the number of schools requiring physical education K through 12 had decreased from about 50% to 29% when we released a report on physical activity in 1996. And that was Dr. Audrey Manley, who as acting Surgeon General released that report. So when I became Surgeon General, there were several areas that we felt should be priority and resulted in reports from the Office of the Surgeon General. Now, tobacco has been a priority for all of us. That's sort of how the Surgeon General report started. So my first report was on tobacco, smoking, and minorities. I did another report on women and smoking, and one on strategies for reducing tobacco use that played a role in the World Health Organization's summit on global smoking. Mental health was a major priority of mine, and that had started in a way when I was director of the CDC and even earlier, because I was concerned that there was no center on mental health at the CDC, given all of the mental health problems with which we were dealing. But not only that, I don't know if you remember, but in 1999, we had the Columbine shooting. And that was the first high-profile shooting in the country where 2 students came to school with guns, killed 12 other students, a teacher, and then killed themselves. And I've often said that the only report that I did that was requested by the White House and the Congress was a report on youth violence prevention. Now, the bad news is that when something like that happens, Americans get up in arms, but it doesn't last. We don't follow through and change policies, make it more difficult for people to get guns. We just rise up after the occurrence, and then when it blows over, we go back to business as usual. Whether it means being more attentive to mental health needs of people and making it easier to identify people who need mental health interventions, we have not responded. I'm really happy to hear that Surgeon General Murthy is going to make mental health a priority. But I'd be happy to respond to questions about our work in mental health and our work in obesity and oral health. This is the 15th anniversary of the Surgeon General's report on oral health. And I was thinking as I saw Renee Jenkins, because there had never been a Surgeon General's report on oral health. And in our report, what we tried to say, just as we said that in mental health, the brain is a part of the body, and you can't completely evaluate a patient without evaluating their mental health, we tried to point out that oral health was critical to overall health and well-being. And with the help of the pediatricians, especially the Academy of Pediatrics, to really urge physicians to become more involved with oral health as a sort of a window to the rest of the body. I've served as both Surgeon General and Assistant Secretary for Health. So I had the responsibility of releasing Healthy People 2010 on January of 2000. And it was in that report that we put forth the goal of eliminating, not just reducing, but eliminating disparities in health among different racial and ethnic groups. And it is that goal that we continue to struggle with. And finally, after leaving the Office of the Surgeon General, I was asked to serve on the WHO Commission on Social Determinants of Health. And what's so important, I think, and the Affordable Care Act does this quite well, even though Congress has not funded it, is that we have to incorporate the social determinants of health in everything that we try to do. And so I think asking the question as to whether, in fact, a patient can walk in his or her community is a critical question. So I hope that that outline at least helps in terms of any questions or comments you may want to have in those areas. Thank you.
Wonderful, wonderful. Thank you all very much for those incisive comments. We're going to get on with the Q&A. Some ground rules as moderator. Keep your questions to a minute or less when you get, or your dissertation, but make it 1 minute. The second thing, I'm going to ask the panel to kind of give us some concise responses, perhaps up to 3 minutes. With that, I'll try and keep a balance and use the microphones. And I see the lovely lady here. Go right ahead with a nice dress.
Hi, I'm Rhonda Maddox. I'm the medical director for the Arkansas Minority Health Commission, and I'm a psychiatrist. Thank you all for putting together a wonderful presentation. What I would like to say first is thank you, Dr. Satcher, for your 1999 report on mental health. As a psychiatrist, I've referenced it frequently and call to action. You cannot have quality health without quality mental health. And so I'm thrilled to hear our current Surgeon General say that mental health is a priority, because it is definitely impactful in the obesity, in the tobacco, and in a number of the other initiatives that you're putting forth in your challenge. Okay. My question to you, Dr. Satcher, is as a person who's working in the community, informing a lot of the health policies, what counsel would you give us as it relates to your mental health initiative or mental health report that you think, if we were following these directions, and certainly for our current Surgeon General, the direction that we should go in implementing those?
And I'm going to try to be brief, so remember this is a brief response. It's a very important question, because I think the community attitude toward mental health and mental illness is a major part of the issue here. The stigma that surrounds mental disorders results in families not seeking care for children when they need it, because they worry about how people are going to think about the child and how it might affect opportunities for the child. Stigma results in individuals who know they need help not seeking it. And stigma results in people in the health profession ignoring mental health needs and saying that we have worked up a patient. The brain is such a critical part of the body that there's no way you can have worked up a patient unless you've asked some really critical questions that relate to mental health. So I think the first thing we have to do is educate the community, work very hard, continue to work hard to reduce the stigma surrounding mental illness, but also open doors. I have been most encouraged by programs of integrated care. And we work with 10 community health centers there in Atlanta, where we're integrating mental health and primary care, training teams of people to deal with the mental health needs of patients comprehensively. And in Grady Hospital, of course, 4 years ago, we took over the mental health emergencies, because so many people with mental disorders would run to the emergency room when they have a crisis, and then you'll never see them again until the next crisis. So we try to reverse that and get people into continuity of care. So I would encourage you to work on that, and would be happy to work with you.
Thank you. Over here, we want to alternate. Yes, ma'am. Mike.
I'm Dr. Sonia Johns, practice in rural Virginia in Joycelyn County. I'm a former solo practitioner in family medicine. Currently, I practice in the Virginia Department of Corrections, and my question, to make it simple, is that we discuss a lot of ignored populations, but it appears to me there are a microcosm of population in the correctional system. And I do not see that population being brought forward as far as disparities in health care. We talk about mental health as a primary reason they're all locked up and thrown away the key. Sexual issues, and of course the everyday and mundane diseases. And I want to know your thoughts on that. Thank you.
Thank you. Dr. Carmona has also requested to make a response to that.
Thank you, Doctor, for that question. It's an important one. We did try and actually had drafted a report on correctional health care. It became a very volatile political issue. The challenge, of course, is that our jails, our prisons, are not just repositories for criminals, they are really mental health institutions. In some communities, there are more mental health patients within a jail or a prison than there are in a mental health hospital. And so when we look at the disparities reflected in those populations, disproportionate amount of people of color, disproportionate amount of people with mental health and substance abuse problems, health is pervasive in that population. And unfortunately, when we worked with the National Correctional Health Group out of Chicago and had drafted a report, but it became so volatile that we were not able to release it. And we had the support of the correctional health care organizations, as well as many other special interest groups, if you will. But I think it's something that still needs to be done. You know, I know Surgeon General Murthy's plate is full, but it's one of those areas that I think deserves attention, because there's a lot of opportunity there to make things better. But let's not forget that in this population, who is, especially in the jails, comes in for a short stay, they get what we would call tuned up from their mental health problem or their drug problem, they get sent back out in the streets, they may be homeless, they don't have a job, they go off their medications, they come back in. It's actually a revolving door, and it's very costly. And it's really a repository for vectors of disease as well. We see HIV, we see hepatitis, we see other communicable diseases in those populations. So it actually is a danger to the community that those patients go back into when they're released from those places. So I think your question is so important, and something that we have to spend more time on, and not to mention the injustice issues that are in those populations as well.
Thank you.
Here, thank you very much. Yes,
Thank
yes,
you.
ma'am.
My name is Elizabeth O'Feely. I am from Morehouse School of Medicine. I'm a practicing cardiologist, and I also serve as Senior Associate Dean for Clinical Translational Research. I do want to thank Dr. Sullivan and the NMA for this amazing meeting, and congratulations to the Surgeons General for inspiring all of us. So what I heard from all of your comments is the urgency of the situation. And in reflecting, so at Morehouse, we have an opportunity to learn how to work well with the community. And I've also learned in collaborating with what we call RCMI institutions, which are 18 institutions around the country that are also working with underserved populations, Hispanics, Native Americans, Hawaiian populations, as well as African Americans. What I have learned is, unless we do something radical, something really different, such as turning how we define success in these disparities, whether it's at the level of clinical care or research. For example, baby steps that we're taking by the NIH to say, we're going to put forth a CTSA, Clinical Translational Research Awards, but if you have minority partnering institutions and communities, they need to define the agenda. So the question I think that I want to pose for all of you, given your vantage points, how can we get to the point where we begin to value differently what success looks like? Because if we use the same metrics, then institutions that maybe write grants perfectly but are not necessarily in touch with communities will continue to get the lion's share of the resources. It is really important to think through and share with us how can we define success differently so the communities that are impacted are helping to define it as well as shaping the methodology. Thank you.
Thank you.
So thank you, Dr. O'Feely, for that great question. I think you're right that in order to change behavior, we have to change incentives and we have to change structure. And one of the things I think that we have seen is that financial incentives certainly can be very powerful. One thing that I learned as I traveled around the country is I would hear from organizations all the time on the ground that would tell me that foundations were funding them to compete instead of to collaborate. And they often found themselves battling each other for funds, where what they really needed to do was to be funded to actually work with each other. So I think funding, certainly from a foundational standpoint, from a research standpoint, funding research in these areas in clinical care, that would focus on disparities, I think would help. But the other thing is, I think we have a really interesting opportunity now where we are rebuilding in many senses and remaking the delivery system, and we're rethinking about what incentives to build in there. And while we are focusing on a number of quality metrics and trying to tie reimbursement to those quality metrics, this is obviously a great, I think, opportunity for us to increasingly keep the focus on disparities, on equity, as part of the quality metrics that we put in place, that are tied to reimbursement. And the last piece I'll mention is around education, which is that when I think about the medical students that I worked with and the residents that I worked with, when I think about my own training as a clinician, thinking about equity was not actually a key part of what we were told to do on a day-to-day basis. Having a lecture once, during medical school or for a few hours, during a block, that doesn't change your practice. But what changes your practice is what your attending, for example, tells you you need to do each day in your presentation, what your hospital gives you in terms of data and feedback as to how you're doing or not doing. And I think that's why we have to actually incorporate equity as a key part of how we train medical students and how we incorporate into their daily practice and assessment of patients and of their outcomes. I think if we do that, education, provide people with the data to assess their own work, change the funding, both from foundations and research, and also shift the quality metrics to include equity, then I think we can take a more comprehensive approach to ensuring that our practice and outcomes reflect equity.
Yes.
Hey, could I just say?
Okay, go ahead.
Because I think this is important, and Dr. Murthy is partly responsible for the fact that the Affordable Care Act goes a long ways toward changing incentives. More than anything we have done, it incentivizes prevention more than any formal payment system that I know of. But it also changes how we define success. It says that physicians will be rewarded not just for the volume of patients they see, but the value of the care, not just for the quantity, but the quality. And Medicare attempts to reward that. Now, we have a long ways to go, but it's really critical. In the area of mental health, the Affordable Care Act goes further than anything in the past. It says that mental health is an essential health service. It says that no longer can insurance companies refuse to provide mental health services. It's essential. We're required to screen for depression. So I just think when you look at how we're defining success, we ought to also take advantage of the opportunities the Affordable Care Act provides.
I just wanted to, it has been so long for people to try to find a solution to the health disparities that I wonder, in the minds of those ones who are searching for a solution, have they decided what is success for them? And this is why I thought that an agenda, health agenda, just for the African Americans, the same that it happened with the Hispanics, might give you a term, date, years by which the completion makes something or someone responsible for the success, but knowing exactly what are you trying to accomplish. And regarding the NIH, having been there all my life before I became Surgeon General, we have a lot of remedial classes for when we want to go into medical school, when we want to go into college. Maybe we need remedial participation at the NIH study sections so that we learn what is it that gets paid, who is the one making the decisions, and how can we learn how to write a perfect grant.
Colleagues, most regretfully, I've just gotten directions from the administration that this will have to be the last question. I think it's here.
Kathy Earls from Atlanta, Georgia, pediatrician, presently, as many of my colleagues have reminded me, gone over to the dark side and working for a pharmaceutical company. And in that capacity, Dr. Murthy, perhaps you can touch on this. One of my frustrations is that there is a disparity of
patients represented in many of the clinical studies, that not just my company, but all of the companies that produce products that affect our patients predominantly. Is there something being done in the governmental level with the FDA to mandate that there be a representative sample of patients in clinical studies of those products that disproportionately affect us?
I think they do.
Who wants to take that? Yeah, go ahead.
I'm happy to start.
Yeah.
So thank you for that question. This is actually something, the participation of people of color in clinical trials is actually an issue that's important to me. It's actually where I began my research when I was in medical school. It was the topic of my thesis actually as a medical student. But it also was actually the foundation of a company that I built later on, a technology company, to improve the participation of people in clinical trials. And one of the things that I think that we have seen, both from a research perspective and in practice, is that one of the biggest barriers to enrolling people in trials is certainly a degree of mistrust that many communities have toward research. Despite what has been explained in the past, there's a lot of persistent mistrust. Second, many times people who are of color don't get asked to be in a trial. And that is also an issue. So we have to both make people think of it, but we also need to ensure that it's being done in a way that engenders trust. I think that some of this is actually, it relates to the workforce issue we talked about earlier, which is that having people who look like you, who sound like you, who share your background, goes a long way toward improving trust and goes a long way toward improving participation of people of color in clinical trials. So that's one piece of it. But the second is that there are, and I'm sure that my colleagues can expand further on this, but that there has been attention placed from a government research perspective on inclusivity in clinical trials. But that doesn't mean that it's easy to do. And therein lies the problem, which is that when you look at it from a research perspective, if you are either running an academic trial or you're at a pharma company, and I've certainly worked with pharma companies extensively during my time running my company, many of them go in with the right intentions of wanting to have representative samples. But the challenge is they find it either too hard to recruit people, or they find that they can't find enough folks who are actually who trust enough in the trial, or people drop out early. So this is why I actually think it's important for us to work on the workforce piece. But let me see if any of my colleagues want to comment on other things that are happening within the government to push that piece forward. Let me just say quickly, though, I think this is why it's very important for all of us as clinicians to remember to ask our patients to participate in trials, because I think we have to recognize that it's very likely that our patients of color are not being asked by other providers to participate. So we have to start that conversation, talk to them about whether they participate in the trial, if they considered participation in a trial, and then get them started on the path through a conversation.
I think that's a very important point, and I'll be brief. As you probably know, Alzheimer's is one of the fastest growing health problems that we face, one of the fastest growing causes of death. Cancer has gone down as a cause of death, diabetes, heart disease, but Alzheimer's is increasing. And African Americans are twice as likely to suffer from Alzheimer's, and yet participation in clinical trials is very low, and there's growing money for that research. So that's an area where we need to do a lot of work. We need some innovations in terms of how we get people. But I think Dr. Murthy's point about the role that physicians play is often underestimated. Stephanie Monroe will be here Wednesday in the community health session from 11 to 1. She's from the Association of Alzheimer's for African Americans, and we'll talk about that issue and what's happening at the national level too.
Yeah, I want to thank all of those who got a chance to ask the very thoughtful questions and the incisive answers that have been provided by the panel members. I do have one last question that was sent to me to be read from Dr. Sullivan. It's not his question, but he is a conduit. It's very interesting. For several years now, the University of Michigan, Medical School of Public Health, Henry Ford Health Systems, and the National Association for State Health Policy have been studying the concept of implementing a state surgeon general model in every state and territory in the country in order to advance the health care reform. How would you, to the panel, how would you envision this position addressing the elimination of health disparities and bridging the gap between medicine and public health? And before you answer, prompted my thought right away. We have surgeons general for the branches of the military, Air Force surgeon, so it gave me a thought. But with that, that question was presented by Dr. Kimberlyn Dawn Wisdom. So,
who was the state surgeon general for the state of Michigan when I was surgeon general. So I hope you're going to comment on that, but I think it's a very important point.
It's to the panel. Whoever wants to comment on that from the panel. Yeah, that's...
Well, as you know, Arkansas has a state surgeon general, and this surgeon general has served very well. I felt that he was really very helpful. But you know, it obviously depends on who it is, what they have in mind, what they really want to do, and how well they work with the leadership, you know, that's in power. You know, it's like being the Surgeon General of the United States. There are a lot of things you can do. You can influence lots of things, and I really think that there is a role. I really felt that our Surgeon General was really very helpful in Arkansas. So I don't know, but again, the governor wanted it, the people wanted it, and the care system there was wanting one, but I don't think we have a Surgeon General right now. So.
If not, well, thank you very, very much. And at this point, will Mr. Josh Jackson come forward to represent the young people here?
Good morning. My name is Joshua Jackson, and it is my privilege and pleasure to introduce the young people who will present the plaques to the Surgeon General. Each plaque gives the dates of service of each Surgeon General and reads thusly: the National Medical Association extends its sincere appreciation and thanks to Surgeon General Doctor in their name for valuable contributions to the 2015 NMA Convention and Surgeons General Summit and the Conference on Minority Health and Disparities, and for the meritorious service and outstanding contributions to the health and well-being of all Americans as Surgeon General and in their dates of service. Presenting the plaque to Dr. Regina Benjamin is Mila Jones. Presenting the plaque to Dr. Richard Carmona is David McElwain. Presenting the plaque to Dr. Joycelyn Elders is Miranda Wilkerson. Presenting the plaque to Dr. Antonia Novello is LaShawn Taylor. And presenting the plaque to Dr. David Satcher is David Taylor. And lastly, presenting the plaque to Dr. Vivek Murthy is Taylor Wilkerson. The National Medical Association, in conjunction with the Detroit Morehouse Alumni Association, say to the Surgeons General, we love you, we thank you, and we honor you for your dedication, your commitment, and your years of service on behalf of all of America. Thank you.
I certainly want to thank our nation's Surgeon General and the former Surgeon General for an outstanding panel this morning. So thank all of you very much.